Hi, my name is Elisa Minkin. I'm a general pediatrician and I'm also chair of the JOMA Preventative Health Committee. And I'm really excited to be here today with Dr. Miriam Segura Harrison. Hi.
Hi.
Dr. Segura Harrison is a board certified family physician who's currently working at Cambridge Health Alliance at Union Square Family Health Center. Did I get all that right?
Correct.
Okay,
Yeah.
perfect.
Great place.
Having completed her family medicine residency at Brown University, she received her medical degrees from Boston University. She's also a certified lactation counselor. Actually, you got your ICBC, I can't remember
IBCLC. Yeah.
that one.
Internationally board certified lactation consultant.
Right. So you're actually upped it to board certified lactation
Yeah.
consultant.
Yeah.
Mazel tov for that. We're very excited
Thank you.
for you.
Thank you.
She's also done curriculum development work in teaching medical students how to support nursing moms and in teaching public health and medical students about the intersection between religion, public health, and medicine. And so I'm really excited to be here with you today. We did another talk before. I think it was on perinatal
Mood and anxiety disorders.
mood and
Yeah.
anxiety disorders,
Yeah.
and that was excellent. And we've been meaning to have this talk for how many months now?
Several. Several.
Yes. So what we're talking about today is the so-called functional disorders. And we're
Yes.
going to have to first explain what they are. I'm just going to start just to give a little introduction because I have it all written down just to make it easy. Um, we tend to think of medical problems as either medical or psychological, but that's overly limiting and leads to poor medical care. Often, I mean, I see it all the time as a pediatrician. People get stuck. They really do get stuck. The brain and body are not only connected, but deeply intertwined. There's a category of disorders called functional. And that I think that title alone is poorly understood. I think a lot of people hear functional and think, aha, that means it's all in your head. And
Right.
it's
But I think it's really more about that there's something that's gone wrong with the way your body functions,
mm-hmm,
which is so important to understand because all of our experience with how our body interacts with the world is through its functioning,
mm-hmm,
or a good chunk of it is.
absolutely true. So, how could we explain what functional means? Because I think we haven't done that yet. We say functioning, but what makes something a functional disorder?
So I think we have a couple of good models to go through. They can help us break this down.
Mm-hmm,
I like that that idea of that the analogy with the smartphone.
mm-hmm,
You can have the hardware, which is the structure, like the actual like physical glass of the phone
mm-hmm.
can be cracked and prevent it from working well, or you can have the software, like the operating system, and then there can be different things like the app can be frozen. And all those things not working well can impair your functional experience of using the phone.
Right. I think in this analogy, the app was the function
The function.
of the
Yeah.
phone, and that the actual physical phone is the structural disorders,
Yeah.
and
So
psychiatric disorders would be the operating system.
the operating system. So,
Yeah.
and I think that all these things are sort of, it's not even distinct categories like this because there's a lot of overlap.
Mm-hmm.
And so there's the other analogy that we had put together of the Venn diagram,
Mm-hmm.
right? That a sore throat would be a very clear structural problem.
Mm-hmm.
You look in the throat, it looks red. There's white patches on it. You make a diagnosis, you swab, you get an answer. It's strep throat causing that sore throat. It's a very clear structural problem. Right? Then we have abnormal thought processes or behavior, like psychosis or major depression,
Mm-hmm.
right, that are clearly based in the brain, or in the psyche, the psychiatric locus, although they're also biologic in a way that's sort of complicated and difficult to untangle as well. And then function, which is sort of how things in the body interact with each other, right? So someone who has chronic severe nausea that's not explained by any tests might have a disorder in the way that the brain processes information from the gut, or might have a disorder in signaling chemicals from the gut to the brain. And all those things might be different. It might be a structural disorder. It might be a psychiatric problem, but we can't untangle it. We don't know which of those things it is. And
Right.
so we call it a functional disorder.
Right. And it all interacts. I mean, you really can't disentangle all those threads. Like I've had people say to me, I know I have a physical disorder. And yet, if you're dealing with chronic health problems, it's going to affect your emotions. It has to.
Yeah. And I
And
think
back
we
and
also
forth.
don't acknowledge that enough,
Mm-hmm.
that that chronic health problems can really cause psychosocial suffering.
Mm-hmm.
And I don't think that we often address that in our treatment plans when we make them with our patients.
Mm-hmm.
So I think that, we need to really, and I do this a lot, is think about how to address like the whole person
Mm-hmm.
when I'm making a therapeutic plan, including the suffering component. Like how are you as a person functioning through your illness? Which I think is more than about how sore is your throat right now.
Right. Right. I mean, a sore throat is an acute problem. You take antibiotics,
Right.
it goes away, and you're done. Or you break an ankle and you get it casted, and you're done.
Right.
So a lot of these so-called functional disorders are chronic.
Right. I mean, I love the example of fibromyalgia, which is
Mm-hmm.
something that I see in my clinic all the time, because um, it happens most often in women. And I think in general, I guess as a society, we kind of undervalue women's pain and women's suffering. And so a lot of patients that I've talked to have really felt dismissed, and not had their suffering recognized by doctors, by the medical establishment, and that's really gotten in the way of them getting better because their pain is not acknowledged as legitimate, or disrupting the way that they are functioning in the world, which is, I think, a big part of functional disorders that we didn't, lay out here in our outline, but I think is very important to get to, is that functional disorders interfere with people's global functioning in the world a lot of the time.
Right. I mean, I presume that's why they're named that.
That's a good point, but I thought it was more like physiologic functioning and
Oh.
also like functioning in the world. Like those are two sort of overlapping and interrelated.
Oh, I see what you're saying. How your body
Yeah.
functions versus your day-to-day, how you
Yeah.
cope.
Like, how are you coping?
Right.
Like, are you able to like load your car with groceries, unload it, make a meal, that kind of thing, that kind of functioning, as
And
opposed to
right. And a lot of these disorders are invisible too.
right.
So
And
you
I
look
think
at
as a
someone, they go to the
society, we really
doctor.
undervalue
Mm-hmm.
and discount invisible disabilities,
Mm-hmm.
and we don't grant enough leeway for people who are struggling day to day with disabilities and disorders that don't have a visible from the outside component.
Right. And I also think that the medical world is set up to deal with the structural.
Right.
And
For
so
sure.
I think that, especially today's day when the visits are often short, right? And
Yeah,
pressured, and
15
you're
minutes,
at
20 minutes.
most
I'm really
10,
lucky. I get nice, unhurried visits with my patients, which is very, very nice.
which is why you can be amazing, because time is the most important thing. I was reading about an herbalist, and I read that she spends an hour and a half with each of her patients. Time is therapy. Time is therapeutic. And
Yeah.
lack of time, and so, but also it's also a mindset. If you have the mindset that I'm just looking for something structural, and the person comes in and they have abdominal pain, and you do an exam and the exam is normal, and you do a few labs and they're normal, the doctor may say, okay, you're okay. And they may even slap a label.
Yeah.
But that doesn't mean they're really acknowledging that there's something going on that's impairing the way the body is functioning and the way the person is coping functioning.
Yeah.
And then helping them come up with a plan.
Yeah. I mean, I think all of those things are really important. And I think that, there's also this other aspect of, the dysfunction in functional disorders does have a lot to do with both the physical and the psychological or psychiatric interacting.
Mm-hmm.
And there's a lot of, and I think that like when I started reading more about fibromyalgia as being a disorder of pain processing, that there's something that has gone wrong in the body's ability to process painful stimuli. That totally was a game changer for me in thinking about how to help my patients with fibromyalgia. And the same thing with irritable bowel syndrome, which is another one that we think about a lot when we think about functional disorders.
Can we go back a little bit and define fibromyalgia and then IBS, so just in case people who are listening don't know?
The diagnostic criteria for fibromyalgia actually have changed recently. They're defined by the American College of Rheumatology. It used to be defined by like a scoring form with a number of tender points that you would sort of press, and the patient would be like very, very tender to palpation on specific places, not really places that you think of as being places for chronic pain, right around the hips, right around the shoulders, inner part of the knees and elbows. That kind of was where people would kind of be very, very sensitive to pain. Now it's more of a global functioning questionnaire that looks at non-restorative sleep, mood issues, chronic widespread pain. And so there's now a scoring scale for the chronic widespread pain scale. And that's now how we diagnose fibromyalgia. And I think it's more inclusive and kind of gets at more people who fall in the fibromyalgia spectrum.
So you're talking about a chronic pain syndrome that we can't find, anything abnormal on clearly.
Right. Like there's
exam.
Nothing on a CT scan,
right?
Nothing on an X-ray that can tell you, yes, this is fibromyalgia. It's a symptom questionnaire of how someone's doing day to day and where they're holding pain in their body.
Right. Because what I'm getting to is how frequently are people with fibromyalgia also having anxiety and or depression?
Oh, I think it's very, very commonly comorbid.
Right. So the question is, it becomes a chicken and the egg. Is it that really they're just taking their emotional distress and it's becoming pain, or is the chronic pain leading them to feel anxious and depressed? Or does it really matter because we don't really know, and it doesn't matter because everybody should be feeling better and functioning both emotionally and physically?
I would say it's like more column B. Like, I think like, I don't care which came first. I just want to help this person get better.
Right. Okay.
I think also like, let's not ignore like the role of trauma in all of this, right? Like, and the role of adverse childhood events. Like those are the things that are real risk factors for bad things happening health-wise. And not just like functional disorders, but like heart attacks and diabetes and like many, many things that are bad are made much more likely by childhood trauma, as are, anxiety, depression, and other like mental health issues. Like, I think that we take a look at somebody and you're not just getting them at that snapshot in time. You've got everything that they've gone through up until that point, until they get to your office.
Right, because I did a talk with Barry Mitzman. I just did it a few days ago. It'll be a separate podcast with her own experiences. And she tells a story of how she had pain in her hands. And she, has she has mental health issues. She has what she calls chronic Lyme, which is a separate controversial topic, which we're not going to get in today in terms of what the criteria are for that, whatever. But she has these things. And she said the pain in her hands she thought was from neuropathy from her chronic Lyme. And then she realized it was her emotional problems leading to pain in her hands. And that was the exact cause of it. So it's unusual that she was able to articulate. I find that most people who have chronic health problems are desperate to be acknowledged as having something real, which it is. Right. Which it is.
I think that like we need to get away from this dichotomy of real, not real. Like, I think that if it's causing you that much impairment in your life, it's 100% real.
Right. But what I'm getting at is I just think about how the woman's uterus, the root is hysteria. Right. Yeah. And that the crazy woman, and we don't get believed, and women in general don't tend to get as good medical care as men do. Right.
Yeah.
We're often brushed off. Our complaints are brushed off, especially if you already have mental health issues.
Take a Motrin, right?
So I think that it's a really big problem because say a woman comes in and she's been struggling with pain, and of course the pain is real. You and I 100% agree. Medicine agrees.
Yeah.
Right. But some doctors might not be trained in that way. They may be trained in, more of the Western structural.
Right. Or they may know that it's there, but they may feel very frustrated or very
that's a separate issue.
Yeah. Very unhappy with having like another lady with fibro.
Right.
Like, I can't, but like, I feel like that's just the wrong way to go about it, because I feel like just because you don't have the magic bullet that's going to make this person better doesn't mean it's not like worthy of your time and attention as a doctor.
Right. But what I'm getting at is I find there's often resistance to taking on that psychiatric mental health component as part of the problem. And what I deal with when I see patients that come in with, functional disorders, and functional disorders, by the way, are not a diagnosis of exclusion. You do not have to work them up the wazoo. You do a history, do a physical exam. There are certain, reasonable amounts of blood tests, but, you can get caught in the workup trap. And you shouldn't. You can make these diagnoses with the information you have in front of you once you do the good
Right.
history, physical, and
Well,
limited.
I'll point out that
I'm not done
like
yet. I'm
most of
getting to a
these,
point. 1 second. I'm
yeah,
getting
well,
somewhere.
yeah, well, I just wanted to point out that
Uh,
most functional disorders have recognized diagnostic criteria
right.
as well.
Right.
And once you're meeting those criteria and have reasonably excluded your like big bad other things that could be causing this,
Right.
like you should move forward with a treatment plan.
Exactly. But people often get stuck, and I think it's because they want that structural diagnosis or that accepted diagnosis as opposed to something that's more complex or mental health. And what I try to do from the very beginning is get mental health on board.
Right. Well, I always view that as like more of help you cope with your illness.
Mm-hmm.
Like, this is not because I think what you have is all in your
Mm-hmm.
head.
Mm-hmm.
It's because you're suffering
Mm-hmm.
and you deserve support through helping you get better.
Right. And sometimes there is a primary psychiatric issue or emotional issue driving this. Like Barry, when I interviewed her with her problem with her hands, happened to be a emotional issue. That was in this particular situation, the clear-cut cause of her pain. But she has other issues
Right.
that are not.
Yeah.
Right. And she said herself, chicken, egg, chicken. At some point, who cares? You're saying it, I'm
Right.
saying it, she's saying it. But I think it's important to not dismiss, and for physicians to hear, by the way, that they should understand that the mental health, it's not either or. It's not that
Yeah.
you should be just working the patient up or you should be sending them off to a psychiatrist. You need to approach them from both angles, often at the same time.
And I think that there's the role of therapeutic presence,
Mm-hmm.
right? You
Mm-hmm.
are working with someone, you're building trust with them,
Mm-hmm.
and even if you don't have an answer to help them feel better right then and there, you're going to try different things, you're going to work together.
So one thing I want to bring up, one thing I want to say is also that mental health issues, they're real. They're no less important than physical issues. And like I said, when someone is, really wants to be taken seriously, and we should always take our patients seriously and their
Yes.
suffering seriously. They may not want to hear that, but I think it's really, really important to address it. And it can be the primary problem, it can be the secondary, it can be the tertiary, it doesn't matter. It's part of the picture.
Absolutely. And I think that like treating someone as a whole person is
Mm-hmm.
a big part of what I do.
Mm-hmm.
As a primary care doctor, and like you're just like, if you try to just like split people into different little bits and say, I'm just going to only work on your blood pressure, I'm just going to only work on your blood sugar, it's not going to work because you're not getting the whole person. And like, that is just what you need to do, especially for a chronic condition, any chronic condition, especially a functional disorder. You're treating a whole person with their whole set of experiences.
Right. And it's so important for the functional disorders because they are that interaction of brain and body. And I'm going to quote this because I love this quote so much from the article that we worked on together for this talk. It's from Pediatrics in Review, December 2020, and it was called Understanding and Managing Adolescents with Conversion and Functional Disorders, just to give it credit because we used it a lot for this.
Yeah.
When the mind and body, it was a great article. When the mind and body do not work together properly so that the body does not function correctly, you get a functional disorder. So that was that definition of functional, where it's not functioning because the mind and body are not working together properly. And so you very often need to deal with both.
Yeah, absolutely. And I think that there was the point that like, sometimes the more you learn about a particular disease state, the more you find out that actually it was structural all along.
Mm-hmm. Or a structural component, right?
Or a structural component.
Mm-hmm.
And I think like the more that we find out about more of these things, we will find that there are both structural and functional components to lots of these things. And I think that that doesn't mean that the therapies that we recommend, which is cognitive behavior therapy, talk therapy, exercise, are the wrong therapy. They're the right therapy. And those are the ways that we change the way that our bodies and brains function to help move towards better health and better functioning. You know, those are not going to be proven to be wrong.
Right. Right. Because there's still how you help. I mean, I know some people, they want to get to the bottom of things. They want to get to the root of things. And the bottom line, like you said, is functioning better. Sometimes it can be helpful to learn more. And sometimes it's just, you're still suffering and you're not getting anywhere where you're trying to get to that so-called root that
Yeah.
you may never get to, I mean, I think we need to have a lot of humility as doctors. And I think also as patients,
Yeah.
we may need to accept the limits of
Yeah.
what we know.
I think the limits of what we know is for to bring on an especially timely thing is long COVID.
Mm,
And I don't know if you've been seeing this. I've been seeing it a little. People with sort of unexplained, prolonged fatigue, sometimes tachycardia, sometimes prolonged muscle pain, long courses of persistent shortness of breath, even after pretty mild illness, and nothing that really physically explains some of these symptoms in most of the people. And a lot of cognitive symptoms, brain fog, fatigue, really hard to treat and really hard to diagnose even. And it's really just your patient saying, I'm not functioning the way that I thought I was going to.
and this
Or
sounds just like chronic fatigue, POTS,
right?
all of these other things. I think that maybe they'll be accepted more now that more people are seeing it in the post-COVID patients. I'm not, because I'm a
Well,
pediatrician, I don't really see
no,
this.
yeah, I mean, I think I see this a lot more
Mm,
as a someone who sees all ages.
mhm,
But I think many people have always recognized that there's a viral trigger to things like chronic fatigue syndrome in a lot of cases, and there's a post-viral component to a lot of
mhm.
chronic disorders, chronic pain syndromes, chronic fatigue syndromes, and if COVID has one, this may be an impetus for us to do more research into this particular pathophys of whatever's going on with this. But again, we don't know what we don't know. You know,
Right, right. And I think that this also brings us to the role of alternative medicine, which is really a separate topic, and we're not going to go into it in great depth. But just at least I want physicians who are listening to this, and I hope that we get physicians to listen to this too, um, can understand what it's like when you're a patient and you're not necessarily given um, an, an a clear-cut answer to what you have or to what to do about it. And I'm not saying we don't have things we can do, because you mentioned CBT and exercise. Um,
yeah, I mean, a lot of times, like especially with IBS,
mhm,
antidepressants are helpful.
mhm,
You know, maybe because they're treating underlying depression or anxiety, but maybe because they're also helping with neuromodulation in the gut.
mhm,
And or tricyclic antidepressants are very helpful for migraines or IBS,
mhm,
or you know duloxetine, very helpful for fibromyalgia. These are all medications that we know act on the central nervous system, but probably also act on the peripheral and autonomic nervous systems as well, right? And I think that's where a lot of functional disorders live, is at this junction of autonomic,
mhm,
peripheral, and central nervous system.
mhm.
um, and sort of there's nerves everywhere in the body. I think we forget that there's a little
Nerves
brain
and
in the gut, and there's
mhm.
a there's like there's nerve ganglia everywhere all over the body, and things like complex regional pain syndrome are very clearly an autonomic dysfunction.
Mhm.
And should be more of a focus on recovery and getting well, and PT and CBT. All these things are very important, but I think that a lot of that is going to be about, or will be found to be about, teaching these nerves how to rewire.
Mhm. I do want to go into what the standard treatments are, but I just want to spend just a minute alluding to why people would choose alternative treatments for these particular conditions.
Yeah,
I
let's
don't know if
take
you
that on.
see it. I want to take it on just at least a little bit. I want to take it on a
Yeah,
bigger level for a different podcast,
let's
because it's
dig
its
into
own.
it.
What I want to talk about when we talk about alternative is, by definition, alternative is non-proven therapies. So what we're telling people to do for these functional disorders is often counterintuitive. You may have someone who has chronic fatigue, and we're going to say you got to exercise every day.
Mm-hmm.
We're also telling them that there's no quick fix for this. It's
Mm-hmm.
going to be a lot of work.
Yeah.
CBT is a lot of work. Exercise and physical therapy is a lot of work.
Did you say DBT or CBT? Although both could
CBT,
probably be useful.
right? Cognitive behavior therapy is a lot of work.
Yes, it is.
There's like the long, slow road and the slow, long road.
Yeah.
So, I think that um, it's very enticing
Right.
to have
Well,
alternative therapies that
there's
often will say,
also
we can fix this one, two, three.
Right. Well, there's also a lot of CBT that's really effective in a short period of time. Like I find
Mm,
it's amazing when I refer patients for CBT for insomnia,
mhm,
for example, and they start sleeping better pretty quickly
mhm,
in most cases. And so some things CBT is really effective and fast,
mhm.
like faster than pharmacotherapy in some cases.
Interesting.
So like I don't want people to be like, oh, CBT is gonna take forever, like for everything. Like sometimes you start feeling, and it's meant to be short term.
Mhm.
Like it's like 10 sessions or less in some cases. But learning those cognitive restructuring techniques is absolutely essential to recovery in a lot of functional disorders.
Right. But, for a lot of these disorders, you have a complex interaction of, often emotional issues, physical issues. It is not going to be fast.
Mm-hmm.
And so I don't know what percentage you've heard of people with these kind of functional disorders getting alternative treatments, complementary and alternative, as they like to
Mm-hmm.
call it. I
Yeah.
would think it's very high.
Well, when I was in medical school, the I went to Boston University, and
Hmm.
the family medicine department at Boston University has an excellent integrative um, therapy program integrated in their primary care, one of their primary care clinics. And they had groups for chronic functional disorders, IBS, migraines, fibro.
Hmm.
And they talked a lot about lifestyle management,
Hmm.
exercise, massage, aquatherapy, aromatherapy, all of these things that are really good for that are really acupuncture, that can be very, very effective in helping people feel better. And I feel like when we talk about things that don't have well defined, identified things that will definitely help, I think we have to think about, well, is an alternative therapy that my patient's interested actively harmful
Hmm.
or likely to help,
Hmm.
or likely to just be expensive and waste their resources and time, or low input of resources, unlikely to be harmful, possibly helpful. Like I think those are the ones that are going to be the high yield and we can help guide our patients towards.
Right. And if you think about the brain body connection, one thing I read in the article that I love to see, because this was for doctors, is it said use that placebo effect. When you're studying something and you say there is no difference because they had the same high rate with the placebo. Like, for example, studies of patients with migraines. Migraine has a very high placebo effect in trials. I think it's like
Mhm.
30% of people respond to the placebo.
Right.
Okay. But wait a second. If it's you, who cares what makes you
Yeah.
better?
You
Who
feel better.
cares what makes you better? So we should
Yeah.
not be taking away what they said in this article is milk that placebo for all it's worth.
Yeah.
Use the placebo. If somebody says, "Hey, yoga works for me," and yoga is something we can even prescribe, right?
Yeah.
Yoga or aromatherapy or any of these kind of things that are not going to hurt and may help, we
Well,
can.
aromatherapy is not always 100% safe and
No?
has to be done safely. Well, if it's done with inhalation, it's usually very safe unless someone has a sensitivity. But
Mm,
topical or ingested essential oils can be very dangerous. And
mm,
people think, oh, it's natural, it's not going to hurt me. But a lot of citrus oils applied topically can cause really nasty contact dermatitis,
mhm.
and some other oils are photosensitizers. So when I hear someone's interested in aromatherapy, I want to make sure that they're doing it safely. And there's a lot of resources out there for safer use of aromatherapy, which is something that I try to guide my patients towards.
They're very lucky to have you because I think that many physicians do not have that training, and that's a problem. I think if you don't know, you can't
If you
guide,
don't know,
and
you don't know. Like
right, you don't know,
you're
you don't
like an
know. I
unknown
mean,
unknown. Yeah.
you know, I want my patients to tell me everything they're doing. I'll never forget when I was taking my daughter had special needs to the hospital for some procedure, and they were asking for her medication list. And I got to fish oil and whatever vitamin. They said, no, 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 I don't want to hear any of that. And I'm thinking, fish oil prolongs the bleeding time. You do want to hear about this.
Yeah.
So
And
it,
I
I
think
get
that
it from the
as
doctor's
doctors, we
standpoint.
always need to be asking about supplements and
Yeah.
alternative
But it's
therapy.
hard though, because I'm just telling you from the
Yeah.
other side, from the 10-minute visit side, when you have an EMR that doesn't even list all these things, you're like,
Right.
no, you can't take this medication. It's not my EMR.
Yeah.
I can't do it.
You can't
But
be
you,
on this. Doesn't exist.
but I don't. Any doctor who's listening to this, I feel your pain. All right, I feel your
Yeah.
pain. You don't have enough time. You cannot necessarily learn all about this. It may not be your specialty. It's a hard situation to be in because we
Yeah.
want our patients to come to us and say, hey, is this safe? Like you knew all about aromatherapy. And by the way, as a pediatrician, I'm very concerned about essential oils being used in babies and young children. It can very often not
Yes.
be safe. Just putting that in there.
Oh,
And I'm just learning
absolutely.
this. I'm just learning this now. It's not part
Yeah.
of our education. It isn't.
Like
It's not even our
I
ongoing
love
education.
lavender oil. Like I love the scent of lavender. And I read some papers about it being an endocrine disruptor.
I heard that.
So
Yeah.
prolonged exposure to lavender and tea tree oil caused breast growth in young boys that was reversible when they stopped using the lavender. So I think like a little bit, it's like also like nice smelling things are part of self-care as well. But I think, relying on it medicinally can be dangerous. So I think that there's really a moderation to be struck with that.
Right. Right. But there definitely are things that we can say as physicians that are clear cut, not going to hurt and may help. And
Mm-hmm.
the bottom line for this to tell a patient is, if you want to try something, ask me. I will try my best to look it up.
Yeah.
Right. I mean, to the best of our ability.
Yeah. And as physicians, like there's the natural medicines database. There's a lot of really good resources out there to help us as physicians help our patients make safe decisions about their care.
Natural medicine database, is that what's
Yeah.
the
I think it's like one of the things like through PubMed, it's through like the NCAM, like the National Complementary Alternative Medicine, NCC, National Center for Complementary Alternative Medicine, runs it. It's evidence-based. Up to date, often we'll have a monograph on whatever the adjunctive therapy is. And a lot of the more recent up-to-date articles include complementary alternative modalities for a lot of things.
Oh, that's good. Up to date,
So,
most doctors, I think, have access to and use.
Yeah. Yeah. And that's, I think, I always will quickly up-to-date things. And like the most recent up-to-date on outpatient management of migraine talks about complementary alternative modalities. And the one for IBS talks about modalities. Can you hear me now?
That's better. Thanks. Yes.
I have to you're going to not see the bottom of my face a little bit.
That's okay.
All right. So everything really is available. And actually at really easy to use point of care resources for a lot of conditions. I mean, that's how I know, that's how I educated myself about a lot of complementary modalities for functional disorders was through UpToDate, actually.
Right. Like I said, your patients are lucky, and I'm glad that you have the time, but you do have to understand for many patients who don't have someone like you, most people do not get that much time with their doctor, and many doctors do not have that amount of time.
Yeah.
Right. So we have to be empathic about it. I think I'm very big on you are your best advocate. You are your child's best advocate if you're talking about your child as the patient.
Yeah.
And try to get good resources, not just from, say mommy groups or, groups that are selling you something. Once they're selling you something, be skeptical.
Yeah.
Right. I mean, it's just a basic principle. It's just a basic principle.
Yeah, no, absolutely.
But we need to learn to, to respect the complementary and alternative medicines as, potentially very helpful things for our patients, especially if we don't have as much to offer them as in some other disorders. I'm not saying we don't have enough. I'm saying that when you talk about lifestyle changes, okay, eating a healthier diet, getting plenty of exercise, getting sleep, those are hard.
They're hard, and they're also so driven by social determinants of health, right? Saying eat healthy and exercise is great when you have unlimited resources at your disposal.
Right.
And not all of any of our patients can do that. Right. And to say that only people who can do those things deserve to feel better.
Right.
Is horrible.
Right.
Right. You deserve to feel better, even if you don't have the time, energy, and resources to put into healthier living. Right.
Or even maybe you have the money, but you don't have the emotional wherewithal, because making changes in your life, real changes, is hard. And it may take 5 steps forward and 10 steps back. And that's just the way it is. Whereas you may find something like aromatherapy that if you do it safely may make you feel better right away.
Right.
Right. And we can't say what's worth it. We can't say what's worth it. I may think, well, it's not worth it for me. I'm not going to get the placebo effect. I find that I never get placebo effects because I know too much. I'm like, this doesn't make sense. So therefore it doesn't work. It's very sad.
Did you see that study about the placebo effect working even if you know it's a placebo?
No, but I just know it doesn't work for me.
Okay.
I get very little help.
Read that study, it will.
I don't know, but I'm very evidence-based. And if I don't see the evidence, I don't believe in it. If I don't believe in it,
Well,
But
I'm
my
saying
point,
like maybe if you saw the article that placebos work even if you don't believe in them, then you'll
I
believe in
tried.
it.
I've tried. Everybody's different. The point I'm making is everybody's different, and what heals one person may not heal the other person. And we should have the respect because we're trying to be helpful and heal
Mm-hmm.
people, not
Mm-hmm.
judge them and not pick what we think works for us, and therefore it has to work for them.
Well, I think also like this is just about like the journey of being with your patient
Mm-hmm,
and meeting them where they're at.
mm-hmm,
Like you're not going to heal anybody by saying I have all the answers
right.
and if you don't follow it it's on you and I possessed all the ability to heal you and you didn't listen. Like that's not great doctoring. That's terrible doctoring.
Right. It'll lead to more frustration and burnout on the
Yeah.
part of the doctor. I mean, I love the
Yeah.
collaborative approach. I mean, to me, the collaborative approach is amazing because it means you're working with them where they're at for what they want,
Yeah.
right?
Yep. Absolutely.
And it's not just about, what you think or what you know.
Also, the
So,
patient's goal may not be your goal.
right, right.
Right. And I think that's why making goals is so important in functional
Mhm.
disorders. Like, what is my patient's goal? Is it to like go a whole week without a migraine? Is it to have the migraines be less severe so they don't interfere with life as much? Are they to have fewer migraines per month? Or it may be something totally unrelated, a functional goal that has nothing to do with the migraines. I think there's a DO phrase attributed to ET Still. It's that anybody can find the illness, but the challenge is to find the health.
Mm,
Right. So if you're dealing with someone who's chronically ill, taking care of someone who's chronically ill, it can be really challenging to find what is still healthy and whole about that person. And I feel like that's where like working from somebody's strengths is how you support their healing.
hmm No, it's really true. And back to migraines, sometimes they'll say, for example, well, you shouldn't eat chocolate because chocolate is a migraine trigger. I'm just talking because I have migraines and I love chocolate, and that's not ever going to
I mean,
happen
I
without
think a lot of
chocolate.
us, myself included, have migraines.
Right, but I'm not giving up chocolate. So if someone sat there and gave me a list of things to eat and they were my favorite foods, I might want a different, you know,
Right.
to look at it from a different way. Even if, like I went to my doctor and I said to her, I think I trigger a lot of my migraines by not getting enough sleep. And she was great in that she didn't tell me, well, so get sleep. Like she was also a physician. She got where I was coming from. And she's like,
Right.
she didn't judge me. And now I'm
Like, how
choosing.
realistic is it for many physicians that we know to get more sleep?
Okay, but I'm working on it
Yeah.
but
Right.
only when I was ready. You know what I'm saying?
Yeah.
Like, or you go in for, all kinds of related problems. It's the way we as physicians should be, right? Is not judging and listening to them and understanding that there's many ways, like you said, to get to health.
Yeah.
Let's talk about some other. We've talked about migraines. We've talked about fibromyalgia. Um, let's talk about IBS a little bit because I don't think we alluded to
Yes.
it. I don't think we got into it at all.
Let's talk about IBS.
I see a ton of it. I see a ton.
I call it Jewish tummy syndrome.
Oh, it's so true.
Because who among us has not had the stress poops? Anyway, I'm being a little flip, but it really can be disabling.
Yeah, oh, yeah.
To have your everybody's brain and gut is connected, and
Mhm.
in fact, the studies that were initially done characterizing the brain gut connection were done in a horribly unethical manner. They connected medical students to a nerve gut reader, and they told them, oh, we see in this that you have a cancer. And then immediately, like everyone's nerves in their gut started firing because and then they're like, nope, sorry, it's fine. Like totally unethical. Back in
Wow. I never heard that.
so crazy. I learned about it in medical school. Unethical, but that's how they sort of determined that the adrenal stress response is connected to the gut. The adrenal stress response is connected to the gut.
Mhm.
And everybody's gut is connected to the brain and adrenals in that way. And stress does impact the gut. And sometimes it goes wrong. People who have IBS is a constellation syndrome. It's a syndrome. And it's just better.
Yeah, it's better.
And we're doing this with video and it's not exactly easy. the constellation of symptoms. There's constipation predominant, diarrhea predominant, and mixed. And there's pain predominant. So in diarrhea predominant, people have sort of sudden onset changes in their stool consistency to diarrhea or to constipation, pain that's relieved by defecation, and it can be really disabling. And it's usually, you do have to do a little bit of a workup to exclude things like celiac or inflammatory bowel disease. But it's so common, and the characteristic symptoms are so present for most people who have it that you can presumptively make a diagnosis of IBS based on characteristic symptoms of that pain that's relieved by defecation and sort of rapid, sudden changes in stool consistency that sort of go along with that pain. And in some people, it actually just manifests as chronic constipation or chronic diarrhea or chronic abdominal pain without that sort of dramatic shift. That's more the, IBS mixed alternating constipation diarrhea picture. But all people who have those kind of functional gut disorders kind of fall under that horrible IBS umbrella. And also it's linked a little bit with abdominal migraine. And it does have a pretty well recognized like neurobiologic basis as well, with serotonin signaling in the gut. And that was actually the basis of some meds that target it, particularly for diarrhea predominant. The medication elocitron, which is only approved for women and isn't really approved so much now anymore, and people don't really use it, but it uses serotonin receptor stuff in the gut to kind of modulate. Where was I with this?
So serotonin, I'm just wondering about the interaction again of the mental and physical health here with IBS, because again, IBS is highly associated with anxiety and or depression.
Well, I think that, if serotonin is going wrong in the brain, it can go wrong in the gut. I think that sometimes when we have a problem regulating neurotransmitters one place, you can get problems regulating it somewhere else. Because we're all one piece, right? We're not just a brain or just a body. We're a brain and a body together, working together with our emotions and our lived experience. So, and what we eat. Like there's also like all this data about FODMAPs, the fermentable oligodisaccharides, polyols, and something. They're like, I'm forgetting what the acronym is,
right,
but
it's a really restrictive diet though. I mean, I think
really restrictive, and not everybody needs to be that restrictive about it also. And I think also some people fall into this trap of feeling that they can control everything that they eat, and that somehow if they just found the one thing that they are eating wrong, it'll fix how they feel. But that, I think, is not always the way to go either.
Right, but I do think that there's people who have these disorders who find that when they change their diet, they feel better. And so we can find a middle ground, not of, oh, okay, it was a gluten and I simply have gluten intolerance. And if I just remove gluten, I will be fine, which is not likely because it's a complex, multi-system problem. But some people really do have that as a big feature. And if they eat healthier, again, it goes back to healthy diet, healthy exercise, healthy
and like
sleep
what
will
is
help
healthy
anybody.
in that context? Like if the main trigger is garlic, right? And they're like, oh, it's so healthy, I'm gonna have a kale and garlic smoothie every morning. Like, and then they're just getting sicker and sicker, and you're like, oh, that's not what your body wants. But a lot of times it's really hard to pin that down, and we sort of say like, oh, just eat healthier, but what does healthier mean for that particular person? Like, we don't always know.
Right. So in this case, I'm a big believer in nutritionists, because if you have a good nutritionist, not a nutritionist who's trying to get someone to be a specific weight and weigh their food, not that kind, but the kind that can help a person get to a diet that's healthy for them and individualize it. So that would be an ideal for me, particularly if someone was struggling also with having a healthy weight.
Yeah. I think that, diet culture is like no friend of any person struggling with chronic illness.
No diet to lose weight. I didn't say that. I did not. We said this before. You didn't trust me.
No. I know that. I just felt like I also had to verbalize it.
Okay. Say it again. We like to say it at all my podcasts at some point.
We're not pro.
We're health and exercise friendly here.
Yes. Not pro diet culture.
No.
But I think that, we also have to sort of put down the lay down the sword of trying to eliminate every dietary trigger for every
Right.
problem, because oftentimes we won't find one.
Right. Well, it boils down to I've got to get to the root of this. No, you've got to feel better. So
Right.
someone who's working on their diet in a way to make them feel better, say remove sugar from their diet and processed food, will feel better, most likely, even
Mm-hmm.
if there is no specific intolerance, than someone who's going on an extensive elimination diet.
Yeah, and I think again that it also does go back to the sort of the fact that we often feel that like processed foods are going to make us feel worse, sugar is going to make us feel worse. It does sort of all come back to those are the things that are convenient and often cost less, and the issues of access around quote healthy food are like real issues. Like
Right.
it's not always so easy for people to change what they're eating and how, because of constraints on time or access or grocery availability or money or a million things.
Right. And
So
it's also the perfect being the enemy of the good. You know what I mean? Like
right.
it is possible to eat healthier. It is possible to have less processed foods, but what that will look like will be different for different people in different situations.
Yeah.
So the nutritionist can be helpful here, presuming you have one on your insurance plan, which I believe everybody should.
Or that there's like not like a 2-year wait list for, like there's a lot of things.
Mm-hmm. I
Or
happen to be
they
very
speak
lucky in
your
my practice. I have a
language.
nutritionist that takes a lot of insurance and is very accessible and is right in my neighborhood and is
That's
lovely.
great.
So I refer people, every other person. She loves me.
That's fabulous. And I think that
Right.
making good use of that is really, and also I'm a big fan of giving my patients handouts from the Ellen Satter website.
I love Ellen Satter.
She's so amazing. Like literally every pediatric and adult feeding problem can be made
Right.
better with Ellen Satter information. And I think that that's also very true. I came across some amazing handouts on medical nutrition therapy for like in a weight neutral health promotion frame. And I was like,
Mm-hmm.
this is so great. Because like the solution to most of these things in many places is like just lose weight, as if it's so easy, as if
Right.
everyone can, right? And I think that but saying like, here are things that you might try that might help you feel better. Here are things that you might try that might help you feel better, which I think is a much more helpful way to frame things.
Right. Right. And back to that for just a minute. Everybody deserves to have health at whatever size they're at and not be told, come back when you lose weight and then I'll make you.
Yes.
Just going to say that again and again.
100%. Let's say that again and again until people listen.
Because not only do women not get appropriate health care, but overweight
Fat
people in
women,
general, overweight women.
right?
I'm being
Yes.
I don't like to use that word.
I
No.
like to use it because that's my preferred term because I feel like I'm reclaiming it. But like I can understand if that's not the word that you would prefer, but that's the word I prefer to use for myself.
I got yelled at once for using the word overweight in front of a little boy. Overweight.
Well, I think overweight is actually worse.
Is it really?
Yeah, because it implies that there's an ideal weight and you're over it.
Okay. I don't know what word I could have used. But anyway.
That's why I like to use the word fat because it's unambiguous.
She would have killed me. Oh no, that would have been way worse. No, but the point is that everybody deserves appropriate, compassionate, dignified healthcare. And it's a big problem. It's a really big problem in our culture and in our medical culture.
Oh, absolutely. Yeah.
So I'm 100% with you here. Yeah, 100%. So I think we talked about IBS enough for now, although really honestly, that is a topic in and of itself.
Yeah, we talked about fibro. We talked about chronic fatigue a little. We talked about migraines.
Well, chronic fatigue and POTS I want to talk about next.
Oh, POTS. Let's talk about
with
POTS.
Chronic fatigue together because they do often go hand in hand. It was interesting how you mentioned POTS in the post-COVID syndrome.
Yes, we are.
So anybody who thinks chronic fatigue isn't a real thing should now accept that it is real.
Yes, it's real. So POTS, right? Positional orthostatic tachycardia syndrome. People who like when they get up from a seated or lying position, often feel like their heart is going really fast. They can feel lightheaded. They can feel dizzy, and they may or may not have orthostatic hypotension, which is when your blood pressure goes low when you stand up quickly. But a lot of them do have orthostatic tachycardia, which means their heart goes fast when they stand up.
Because that's what POTS stands for, right? Positional orthostatic tachycardia syndrome. Okay.
Yeah. it can be really disabling because people feel really awful when it happens. And it can make them feel lightheaded. It can make them feel really tired. And it can really impair people's ability to do their day-to-day activities. It's something, I think that from the pathophys perspective, our best guess is that something has gone awry in the way that the autonomic nervous system signals to itself and to the brain to regulate heart rate and volume, like how much liquid and pressure is in those arteries and veins and lymphatics that sort of move things up and down in the body when you get up and sit down. Is that a good explanation?
It's an excellent explanation. I just want to differentiate it from the more typical vasovagal, because I have plenty of my young adults who faint easily. They do not have POTS.
No. So vagal tone is usually higher in kids and young adults than in older people. And it's really high, like in babies, like if you are, and I deliver babies, so I see this as if you have, a baby who's delivering, the heart rate will drop right when the head is being squeezed, because their vagal tone takes over and their heart rate goes down. And it's like the equivalent of a grown-up fainting and their heart rate going down, or a young adult or kid. So vagal tone is something that we all take very seriously in obstetrics and also in family medicine obstetrics, and in, everybody should take it seriously because it's a big deal. Or, if you put in an IUD and your patient faints, that's happened, or, do any kind of cervical exam, it can make somebody faint because it can trigger a vagal response.
So that's different from POTS. And
I think it's different from POTS just because the mechanism is different.
But also POTS is associated with other things as well, right? It's not just simply a tendency to faint.
Well, I mean, are we talking about like the MCS and mast cell activation syndrome and those things, or
no? We're just talking about chronic fatigue.
Okay,
and how
there's
a
whole other spectrum of things that POTS can and cannot be associated with that I think is like too big of a topic for us to unwrap right now.
No, more in the functional class of disorders. There are people who faint easily but are otherwise completely fine.
Yeah, I don't think that's disordered in any way. I think that's just like that's the
part of being a teenager.
Yeah,
right.
Yeah.
Part of being a teenager, but some do have more of a tendency to faint, and I say,
or a Victorian. Wearing corsets.
Done with those at least. Carry your water bottle, have your salty snacks, put your head down and your feet up, and be aware that that's your tendency. But people with POTS have a whole other set of issues to deal with, often overlapping with chronic fatigue.
Yeah, and I think like some of those suggestions that you made are also useful for people with POTS. And you tell them like stay hydrated, don't get behind on fluids, liberalize salt in your diet, wear compression stockings, all those things that can really help somebody who's A, prone to fainting, but also B, has POTS, like helpful in either one of the scenarios.
But I think in these, they often have more of an exercise intolerance. Correct me if I'm wrong, because I don't.
No, I think I'm just starting to see it. And I think like it's also in the people that I'm seeing it with post-COVID, there's also an element of deconditioning because it's after an acute illness.
Right.
So there's just a lot going on there to unpack.
Right. If you're people with chronic fatigue or people who have, been sick and deconditioned, these are the people who are the last people who want to exercise.
Right.
And yet that is an important prong of getting better.
Well, and also like we were telling people in acute COVID not to exercise because of myocarditis risk with exercise for a while. And the guidelines changed back and forth on this, but now our guidelines are graded return to activity, which is what is recommended for POTS as well, is graded return to activity. So exercise a little bit every day and fast enough to change your breathing, which I think is like a much more useful metric than like can talk but not sing. Like what does that even mean? Like
Right.
Like I don't routinely sing
while
I'm
I walk.
exercising. row. No. But fast enough to change your breathing is, I think, a helpful metric because it shows that you're exerting yourself a little. And I think also like being mindful of like the chronic pain part of fatigue is it can hurt to move your body if you're deconditioned. And it likely will hurt after you've moved your body, and like
Right.
normalizing that for people, like you might hurt a little bit after this.
Right, because we're used to the normal recovery period. You wait till you feel better and then you start moving and you do it as tolerated. We see return to exercise as tolerated. But for this category, for someone who's struggling with chronic fatigue and chronic pain, it's going to mean they're going to have to go against the discomfort now, because if they wait, they will not get better, they will get worse.
Yeah.
That's hard.
Yeah. And I think that, we really have to like be there with people. I feel like I say this a lot. But let's make a plan. Do you think you can stick to this plan? Like, what's it going to look like for you? How is this going to fit into your life and your responsibilities that you already have? And like, then you check back in, like, how's this working out for you? And I think that actually this is why physical therapy is so helpful. Because it helps people get their strength back. And so I really like referring people to physical therapy for stuff like this. And even for fibromyalgia, like I referred a patient to fibromyalgia. Sorry, I referred several patients actually to physical therapy with fibromyalgia. And like, it's like really, really dramatic, like how much it helps people. You really just like sometimes need somebody else to guide you through it. And like, I don't know, like, I guess maybe personal training would work for that too, but like physical therapy has like its own magic and its own knowledge of like how bodies work that I think is
right. I think the difference is that, many people who are going for physical therapy have certain areas that are weaker than others. Right. Someone who just wants to be reconditioned, who doesn't really have chronic health problems, can go to a coach. But someone who is, has specific weaknesses or, discrepancies, certain areas that are more painful than others, who needs to learn how to move them, that's where physical therapy shines.
Yeah. Also things like cardiac rehab and pulmonary rehab, which you probably don't see a lot as a pediatrician. But I have like, and this is not functional disorders. I'm usually sending patients with structural disorders to cardiac and pulmonary rehab. But along those lines, like lung function is something you didn't really think you could improve, right? But like, that's not true. People can improve their lung function. Like pulmonary rehab is amazing. Like I didn't even think that could happen. But they make goals and they work on them and people's breathing gets better. And I was like, that just totally blew my mind when I learned about pulmonary rehab. And when I saw how it worked in patients that I'd sent to pulmonary rehab.
This is a little off topic, but I'm saying it anyway. There's this man that they call the Iceman. Have you heard of him? Wim Hof?
No.
So he is in the Guinness Book of World Records as being able to tolerate colds like better than anyone. And he's got a whole method. It was actually in one of the Jewish magazines. I think it was Wellspring Magazine. This whole method of going into ice water, you should take cold showers, that you will tolerate colds better if you can learn to. You can change your cold tolerance. And I think that the idea behind it is similar in that you may think, well, I have to do what feels good, and yet it's no pain, no gain.
Yeah.
Right? Or no discomfort, to put it nicer. No discomfort, no gain. So it's the same kind of idea all around.
Yeah. And I think also like things like specific phobia therapy, like a lot of things are kind of based around that principle. And like, I think I'm sometimes skeptical of it. I did read a critique of the standard therapy for fibromyalgia recently, that overexertion actually worsens pain in fibromyalgia. So I think that just, I think, gets back at the individual goal-based therapy. So like, it shouldn't be like what anyone else thinks is return to therapy, but it should be what that person thinks is return to return to function and return to activity.
Right. Have you ever gone to the doctor and they tell you have to eat X or do X, and you're like,
you're like, nice try, doc.
It has to be for you. It has to be where you're at your, pace. Same thing with therapy. There may be a therapist that may feel compelled to push at a certain rate and the patient may not be ready.
Or like, as a lactation consultant, if I tell a mom, like, actually, you have to pump 8 to 12 times a day. And and I see
Sure.
like that's clearly not going to work for this
Right.
family, you know, or like I get a look like, what planet are you living on, doc? You know,
Right.
you know, and like that's an opportunity to troubleshoot. Like that's where I'm coming from, but tell me where you're coming from.
Right.
Like,
Maybe you want to do bottle and breast at the same time
yeah,
and just a half
yeah,
and half. Maybe that's what you want.
yeah, yeah.
Maybe you want to just start bottle feeding because it's all too much. You know,
Also
everybody's
fine.
different. Yeah.
I'm very like when that like I do not think that breast is best for every mom and every
Right.
baby. You know,
That
like
is best. That is
yeah.
best.
I think that there's just like an individual plan that's out there that's right for every individual person, but there's no one plan that works for every person.
Absolutely. Other points that we should bring up would be, I think we've said a lot about being there with our patients. And I think, you know, being there as we go through the process and not getting frustrated if their rate is not the same as our rate of recovery.
Yeah.
Right.
Or our expected rate for them.
Right.
Yeah. Like what we think they should be doing.
Right. Or
Yeah.
something that we thought would work didn't work. I mean, I've had people get very frustrated at patients because what they were telling them to do wasn't working.
Like, how dare you not be better?
I know, right?
So
I had a
awful.
patient with an eating disorder and they were telling the mother to get her to eat, and the mother couldn't because that's why she was there in the first place. It was very sad.
Yeah. I mean, like, I don't know. That just drives me crazy. Like, you're not in charge, you know, like
Right.
you don't like, I don't know. I feel like this is part of where our religious beliefs kind of kick in. And it's like, I'm not in charge of the outcome here.
Right.
You know, like there's, you know, forces that are not me at play here. You know, and I think, you know, we have an amazing responsibility, but we also like can't take on the role of saying like, I am the person who can fix this. Like, no, you're not in charge of fixing this. Like you're in charge of guiding people to tools that can help them heal.
Right.
You're in charge of being with them in their suffering, but you're not in charge of their healing. You don't hold that key, you know?
Right. And that is a beautiful way. I'm going to stop with your words because I can't do better than them. But this is going to have to be continued because this is really just an introduction to a whole bunch of disorders that really each deserve their own talk.
Absolutely. Absolutely.
I thank you so much for doing this with me.
Thank you. This was great. We should do this again.
Yes.
All right. Thanks.
Thanks.
Bye.